Hi, how are you?
Doing well. Good morning. How are you?
Doing excellent.
Good.
I'm so excited about the podcast.
Well, I'm equally excited.
So I recently went to a sleep study with Vivos.
I saw that on some of your socials. Yeah, where you'd been to Denver.
Yeah,
Yeah, I've got a lot of friends with that company.
so I have a lot of questions for you.
I hopefully I've got a lot of answers, or if we don't know, we'll find out where to put it in the show notes later. If we can't answer right now, but
Awesome.
I'm happy to talk with you about anything you want to talk about.
So tell me a little bit about you.
Well, this is my 28th year in dentistry. I've been a general dentist, my entire career. Have kind of limited my practice to clear aligner and sleep over the last 7 years. A lot of it in the telehealth world, kind of helping larger companies with lots of cases across multiple states. But I am a Vivos VIP, and I'm one of the Vivos trained founders of Tooth Pillow, which is the children's organization. I don't know if they mentioned that at the meeting you were at. Was Chad Rasmussen the host for your meeting?
Yeah, he is awesome. I love Chad.
Yeah, Chad's the CEO of Tooth Pillow,
Yes,
and then it was were Dr. Moralia and Dr. Hale both there as well.
yes.
Yeah, Callie and Ben. Yeah, they're Ben's the real reason that I'm a part of that, because I really respect him, and he's one of the reasons that I became an airway centered dentist, was listening to him, and he's brilliant, and I'm so grateful to have him in my life as a practitioner, and be able to bounce ideas off of him and treat patients with him. It's been really cool.
So as a reconstructive biological dentist for like 30 years, when I took, I have been to various sleep apnea companies and, their seminars, and I was very impressed with the Vivos, organization and how well they have everything kind of falling into place. Now, I would love to know more about, how do you treat the adults? Because, most of my practice is adults, and I understand that the consequence of not breastfeeding and the soft foods and how that affects the children. But like everybody I'm treating has sleep apnea,
Oh, I know.
and
Yeah,
they can die from it.
it's so prevalent. Well, basically, when I treat adults, I try to figure out the best way to get them the expansion that we wish they would have gotten when they had conventional orthodontics when they were 12, 13, 14 years old.
Right.
Only about 30% of the patients that are treated with the Vivos expansion appliance see absolute complete resolution of symptoms with sleep apnea, but about 80% of the people who wear a Vivos style expansion appliance have marked improvement in their sleep apnea. And so I treat adults with a combination of things. I really treat them each one in a custom way. If
Right.
I if I feel like that I can, we have companies like Candid and OrthoFX out there in the clear aligner world that understand airway and understand. I mean, Pete Menjo from Candid just texted me this morning, and Dr. Moralia is a Candid preferred provider, and he does a lot of coursework for them, and they are actively listening to doctors who want to expand adults every day, and so they're trying to get their systems in place where they can treat adults with expansion, because as we know, we want 40 to 41 millimeters between 3 and 14, the upper first molars, if there's a way to get there. And if
Mm-hmm.
I can get there with aligners, that's what I'm going to do. If somebody's only 3-4 millimeters deficient, I mean, I was at a meeting in New York City in May, and there was an oral surgeon who took a patient through a $43,000, Lafort One massive surgery to get
Right.
4 millimeters of
Whoa,
overjet improvement. And I'm thinking,
that is
that's
crazy.
terrible. Why can
Yeah.
we not, and they were laughing about how all the oral surgeons residents were fighting over the opportunity to get to do that case. And I'm like, I'm glad you guys want to cut on people really bad and you think it's
Cut the
funny.
jaw and maybe
But
cut the
this is,
artery, and the patient can die.
I know, it's like, why does the answer have to be no? Why can't we we'll look at all the minimally invasive things that we can do first. And that's why,
Right.
I love treating the children, because I know I can expand every single child. I
Yeah.
know and the kids are a lot easier to treat. The adults are
Right.
a real challenge. And
Right.
some patients just need to have a CPAP. That's what they need. Most
Right.
people can't tolerate them. So
Right.
so there are some patients that don't want to be expanded. They just want to breathe. And so
Right.
those patients, I make, mandibular advancement appliances for those patients.
And how much can you get with a mandibular expander, like,
As far as advancing the mandible,
yeah,
8 to 10 millimeters of
that's
moving
very
and moving
impressive.
and moving, but all you're doing is moving it forward overnight, and then you're using a repositioning bite appliance in the morning to put them back. We tell them, when you're having your coffee, just put your little chew appliance in there, and by the time your coffee's done brewing, your bite will be reset in the morning, because we don't want people walking around with an open bite. But
Wow.
basically we're moving them, and we start conservatively, but we move them, 4 to 5 millimeters in their first appliance. But it's just a Herbst. It's a Herbst appliance, with little cylinders on the side. And there's about 5 different companies that all make pretty good devices. Some of them even 3D printing them now.
Mm-hmm.
So, but one of my colleagues and one of my mentors is Dr. Barry Chase,
Mm-hmm.
and he's in New York, and he's never expanded one patient, but he inserted 237 appliances in the month of May while I was there. That's a lot of cases.
And he fixes the sleep apnea problem
That's
with
right. He does an AHI before and after treatment, and he takes patients from 29 AHI all the way down to 4 by just moving their mandible forward a little bit at nighttime with an appliance.
right.
There are some patients, if they have mild sleep apnea, you can use a Fotona laser or a Solea laser and
Mm-hmm.
laser their soft palate. And sometimes that's all patients will need to correct their apnea.
Wow.
I have a colleague in Colorado Springs area, Denver area, Kevin Goals, and Kevin, he had a patient with an AHI of 39 and took them all the way down to like point something with just laser.
So for the people that are listening to us, they don't know what HI is. So, you want to explain that to the public?
Sure. I didn't know we were recording already. Okay. Yeah. AHI is what we call the apnea hypopnea index. And it's kind of the general standard measurement for medicine and dentistry to determine whether or not a patient has signs of sleep apnea. And so what it registers is, of course, in dentistry, we do it with a little ring like you wore at the conference when you were there. I'm pretty sure they're still sleep testing the doctors when you show up at those events. Just coincidentally, how many doctors actually had sleep apnea readings? Do you remember how many they said?
They didn't say, but in the table that I was sitting, 4 people, 3 people had it. One was a young dentist. She was in her 30s. And the only one that didn't have it was the dentist that was in her late 20s.
Yeah.
Yeah.
Well,
Everybody else had it.
Yeah, it's well, back to the AHI. We use, I love the sleep image ring. Wesper makes a nice ring as well. I'm not as familiar with their sleep studies, but I've analyzed hundreds and hundreds of the sleep studies. And the detailed information, when you send that to a medical provider and you say, hey, we've done these, they're so amazed. They're so grateful for the data. And especially, if you send a CBCT along with it. I mean, we've got ENTs out there who do very involved invasive sinus surgeries and never take a pre-op x-ray when they do it. So, we're gathering a lot of really good diagnostic data when you're treating an adult. But that's what AHI stands for. Apnea, just APNEA, meaning without air.
Yeah.
The PN prefix from where we get our words pneumatic and pneumonia, having to do with air.
Right. So a good reading of somebody super healthy would be what?
Less than 5.
Less than 5.
Less than 5, yeah.
And if somebody has like 100,
they should probably be hospitalized today.
right? Because
Yeah.
they're not getting enough oxygen. So,
That's right. Well, an AHI of 29 or higher is considered severe sleep apnea, meaning that you're stopping breathing
yeah,
29 times per hour at an average length of 10 seconds per time.
yeah,
And, and like you did at the exercise when you were in Denver, I mean, if we just hold our breath right now on the podcast, I mean, I held it for 11 seconds, but when you hold your breath for 10 seconds, I mean, you're really ready to breathe again, even when you're awake and you're under control of what's going on. And
yeah,
I've had just about every patient that that I feel like has signs and symptoms when we see them diagnostically, when we do a sleep study on them, invariably those patients will have at least one episode where they stop 68, 70 seconds, at night without breathing. And that's why we see all these heart attacks at nighttime, because
right.
the heart attacks, it's number one cause of death in the United States
Mhm.
still here in 2023, even though we've been
Right.
telling everybody, eat less trans fat, make sure you're moving your body and exercising. We just continue to, to eat KFC and drink Mountain Dew, and and so we end up with the bad diet. And
Right.
when these patients have a heart attack at nighttime, it's because they've got this cardiac coupling going on, where this cardiac trampolining rather going on, where their heart rate is responding, right? They're in fight or flight mode because their body is saying, hold on here. This human being is not getting air. They're not getting oxygen to their brain. So let's crank up the adrenaline. Let's crank up the heart rate. And so when you have this cardiac issue from time to time, I mean, I have a dear friend who just was not feeling well. She had some dizziness and just wasn't feeling well, and she thought it might be her heart. And so she went to have an evaluation, and she had some left ventricular enlargement of her heart.
Mhm.
Well, it was because she, in fact, had sleep apnea, and her
Mhm.
left ventricle was pumping a lot harder. And so it's just like, working out your biceps. When you work out the left ventricle like that, it gets bigger. And so she
Right.
had some hypertrophy because of that, and it was secondary to sleep apnea.
Yeah. I'm like evaluating, like the patients as they come. And I do a lot of full mouth reconstructions, opening vertical dimensions, opening the space. So I have seen a lot, because when we sedate them and we put them with the EKG and the CO2, we see when they don't get enough oxygen in their brain. So one case, I told the patient, you have sleep apnea. You have to like go and get a sleep study. This is really bad. The machine is going off all the time. So she went and she got examined. When she came back, her son, that was in his early 50s, had passed away that month from sleep apnea.
Wow.
And she said, I wish that he had a dentist that would have told him about sleep apnea, because we are the first line pretty much. We see the people
That's
first.
right.
We're seeing the people, we see all the physical evidence. So in your experience, what are the things that you would tell the patients, that you're seeing that is an indicator? Why don't you share with our audience that part, since you're an expert in this field?
Sure, happy to. Um, Basically, what I've been doing since that's part of my journey is I was diagnosed with apnea myself. So I actually wear a CPAP machine. I have a Vivos appliance. I'm in the process of expanding myself, but it's going to create space, right, in my
Right.
teeth. So then I'm going to need I'm going to do probably some Durathin veneers. I don't have any crowns or tooth decay or anything. So I'm going to probably just put porcelain veneers on when we get finished. But I'm
Mm-hmm.
under treatment myself. So I understood as a patient, and it really changed everything for me as a provider, because when I sit a patient down in the chair now, our hygienists take blood pressure on patients every time, and a lot of
Right.
dental offices don't do that. So doctors out there, if you're general dentists, guys and gals, if you've got hygiene departments that are running behind and you're letting your staff do 30-minute prophy, shame on you.
Right.
Spend more time with your patient
Yep.
and ask questions, take blood pressure. So if we've got elevated blood pressure, let's say that I see, Yolie comes into my office and she's 100% healthy and fine at one hygiene visit. And then 6 or 7 months later, she comes back and now all of a sudden she has elevated blood pressure.
Mm-hmm.
She's not aware of it. because she's single and doesn't sleep with a partner at night. And so she doesn't hear herself having breathing issues. And so we take blood pressure, and we also, ask a patient, how are you feeling? How do you sleep? When's the last time you had really restful sleep? If they say anything other than, oh, wow, I slept great last night. I went to bed early. I got up early. I wake up without an alarm clock. If they say anything different than that, most patients, when they pause a long time, they can't remember. I mean, most adults, that have any other signs of sleep apnea or sleep obstructed breathing, they can't remember the last time they had restful restorative sleep. And so these
They
patients
wake up exhausted.
They do, or they wake up. I had a colleague of mine who was a banker, and God forbid, all your listeners out there, don't do this. Don't go have a surgery on your oropharyngeal region by an ear, nose, and throat person without looking at the whole picture, because everyone I know who's had a sleep apnea surgery tells me it's the worst thing they've ever experienced in their life. They couldn't even eat Jell-O at all for 6 or 8 weeks. It felt like their entire throat was one giant mouth ulcer that just had to granulate.
So what kind of treatment did they receive? Lasering of the trachea?
Oh no, I think it was a physical incisive surgery of like flaccid tissue in the oropharynx. And this guy was 6'3", probably 175, 180 pounds. He was not overweight.
Right.
But he was having headaches. Every morning he would wake up with a headache. Well, that's another sign or symptom. If you have frequent headaches and you're properly hydrated, most of the US is not properly hydrated. And so if you're sitting out there and you don't have an 8 or 10 or 16 ounce bottle of good distilled alkaline, hopefully a glass bottle, with drinking water in it within reach at all times, you're not hydrating enough. And so if a well-hydrated patient is having headaches every morning when they wake up, that is a sign of oxygen deprivation. And so, that's a concern. And that was his major symptom. Was I just thought I was getting old. He said, because I was in my late 50s, and I thought, okay, well, this is just how you feel. And he said, I woke up with a headache every morning, but he had sleep apnea, as it turns out. So as a dentist, what signs and symptoms can we look out for? Venous pooling, dark circles under the eyes, or big bags under the eyes, or, if that's an indication that someone's not sleeping well because their eyes are strained and they've got a lot of inflammation around their eyes, that's a sign. As you know, from opening patients' bite and increasing their vertical dimension of occlusion, a deep bite is many times a sign of sleep apnea, because if we have a deep bite, that means that the mandibular and maxillary molars are close together, because by definition, a patient's overclosed. So their upper incisors are touching the gums down on the lower teeth. And so what do we need? We need to expand the molars so that the molars hit sooner than they do now, and open the bite. And so those patients, patients that have deep bites or lower crowding, any kind of crowding,
and those
almost every human being really that I look at almost every day, unless they're a really well done orthodontic case, needs expansion in some way.
Well, remember that in the 60s and the 70s, the orthodontists used to extract premolars and take teeth out to do the ortho. And all those patients, all of us are collapsed, because they took like teeth that we needed because they didn't know what they were doing, and now we need them back.
Yeah. Well, one of my buddies, Brian Ferry, that we're co-writing a book together. He used to, when he talks about, if you couldn't fit a foot inside a shoe, would you just lop off the pinky toe? You wouldn't do that. I mean, and so why do we do that with teeth? Why do we take out teeth when really what we need to do is make sure we have the foundation in place so that all the teeth have the right amount of space to erupt.
Exactly. Right, exactly. Yeah, I like that analogy, because everybody wears shoes. So I like that. Everybody can relate to that. So a lot of the patients are concerned about when, say, if you're going to do expansion of the maxilla and of the mandible, and you're going to have spaces, what would you recommend to an average patient? Implants, or, to do kind of crowns that are wider. It depends on how many millimeters you have available.
Yep. Well, I'll start by saying you want patients to know this on the front end. In other words,
Right,
when you start treatment, you need to tell them,
right,
hey, we're trying to create more space in your arches. So you will see some spaces occur. And you may have space between your front teeth. Patients that have large anterior bonded restorations, composites, sometimes those can dislodge because food
right,
is hitting them now when it wasn't before. So, your dentistry may change, you may have space. But the thing is, most of my patients they feel so much better after
right,
having that they're happy to have the space because they'd much rather have a little
right,
space and then breathe better and feel better. But the
right,
space we can always fix, right, with like what you do, doing some beautiful veneers for them,
right,
after the fact. But I don't think I've ever had one patient that we expanded so much that they had to have an implant. In other words,
right,
now you mentioned somebody having serial extractions, for orthodontics as a child.
right.
I suppose if we expanded that patient to the ideal amount, in theory, they would have all the space back for, a full premolar in each arch.
That
And
would
if
be
somebody,
amazing. I
yeah,
would
and
go
if
for
somebody
that.
does have that, then we would do implants, of
Yeah,
course.
yeah. The concern of cosmetics on patients that are vain versus, surviving and getting enough oxygenation into your brain so you don't have brain inflammation, develop dementia later on. The consequences of not getting enough oxygen are humongous. And we have a growing population that is the dementia and Alzheimer's is duplicating by the year like 2030. It's really significant, so this is like a fact that, it's a blind spot. Most people don't think about, you only hear about the wife. I had a patient, please fix my husband. He's not so loud that I cannot be in the same wing of the house. It's like the house shakes. Is that
Yeah,
bad? But she thinks he's going to die in his sleep,
she's right.
you
I
know?
mean, not to be crass or too gruff about it, but she's absolutely right. I mean, and that's one of the other problems we have with snoring. We watch Snow White and the Seven Dwarfs, and it's funny, that the dwarfs are making noises while they're sleeping. And I can't remember which one of the Friends cast had snoring issues. It may have been Joey but we make fun of it.
Right.
And snoring is kind of a funny sound if you listen to it audibly. But when you think about the fact that that's somebody who's struggling to breathe,
Yeah, they're dying.
then it's not humorous. Yeah.
Right. So, from your experience, say this patient that I'm speaking about, his mandible is underdeveloped like 10 millimeters. He's like,
Wow.
you don't see his bottoms. He's totally collapsed. He's got a
Yep.
big upper arch. Can you expand that mandible? Like you said, 8 millimeters. I think
Oh,
8 millimeters would do a difference.
well, now when I was speaking about mandibular advancement, I wasn't speaking about actually moving the teeth. I was speaking about an appliance that a patient wears to advance their
Right.
mandible at night.
Okay.
Um, and
But is
so
it possible to make the mandible bigger?
I think so. But I think he would need orthodontics to do that. Yeah. And
Right.
I think you could, take him through an archoir sequence or have your orthodontist do that. And that's where I would start, that and looking into some expansion, especially if his larger, and it may be that he's a Vivos candidate, for an upper appliance where he can get, but it sounds like he's not in crossbite though, right? He just has deep bite.
He's got a huge maxilla and then a underdeveloped mandible.
Okay.
So
Well, I
he's
would
got
just,
the tongue
if
doesn't have any room.
yeah, tongue has no room. Well, yes. So somehow we've got to get the intra arch distance between his lower molars to be greater.
Right.
And so whether you do that with a combination of orthodontics and an expansion appliance, all the dentists and oral surgeons and orthodontists that taught us back when you and I went to dental school, said, oh, well, he's a surgically assisted palatal expansion case is what this patient is. And, I wouldn't want that done on me first without at least looking into a removable appliance of some kind.
Right.
But it is possible there are patients that still need, sagittal split osteotomies of the mandible to move to, actually
Yeah.
lengthen the mandible if we
Mhm.
can't get there with just some orthodontics.
Wow. So, this is so amazing. And tell us about the book that you wrote and, how can people get it?
Sure.
Because it's
The
right
book
at
is
the
called What
time,
Happens When That's right. It's called What Happens When Your Child Doesn't Sleep, and it's
Mhm.
co-written with my buddy and my brother, basically Brian Ferry. And Brian used to be, they called him the director of evangelism for Vivos, because he was the chief marketing director at Vivos for a long time. But Brian tragically lost his wife 8 years ago to complications from sleep apnea, and she had 2 CPAP machines wrapped in the plastic underneath her bed at the time of her passing. So, and she was being treated for a whole myriad of other things, anxiety, depression. She was on multiple, pharmaceuticals, prescribed by doctors, but her sleep apnea, as far as we know, was never addressed. And so, Brian's been on a crusade to teach more people about this ever since he lost his wife.
Right.
And his background's in marketing, but when Kirk Huntsman and the folks at Vivos met Brian, they were like, we have to have this guy help us and try to tell the story. So that's what Brian and I are really doing. And we know for 100% sure that we can expand children, and we're having success with that. So that's why we want to let parents know, because there's so many folks out there. I'll give you an example. I had a mother in Michigan the other day, and we spoke by phone after she was trying to decide what kind of appliance to do for her child. And there is an online way that we can treat patients now for that. And that's with our company that we call Tooth Pillow, which Chad is the CEO. We mentioned Chad Rasmussen earlier. Chad's the CEO of Tooth Pillow, and you can go to toothpillow.com. You can download the Tooth Pillow app, and parents can put in the data about their child and answer some questions, and then upload some photographs and have same day approval for an appliance for their children. And it's not a custom made appliance. So Vivos makes the appliances, and we ship them out to the patient. They typically get them within 1 to 2 weeks after uploading the data. And so Brian and I knew that, we could treat these children, but still we felt like that the story was not being told. And so that's the reason for the book is can we talk to Dr. Yolie and other people that have podcasts out there and share with as many people, 200, 300, 1,000. I'm on a podcast in January that has 37,000 daily listeners. So just little blocks of people, a little bit at a time. We just want to keep telling the story. See if we can help more people.
Yeah,
these
we are evangelists for health because, there's information is out there. Every day I have patients telling me, if I only knew, what you're telling us, if I only knew, and you would be shocked because we live in the richest country in the world. We have so many avenues of education, many too fragmented, like in the past,
Yes.
they had one newspaper, the New York Times, everybody read it. And now in Florida, they have some Sentinel, but now there's so many fragmented communication that people are not getting the global information. And then the global information on TV is not exactly educational. It's more like drink Coke and, become a diabetic.
A lot of it's advertising. You're exactly right. But and in the US, we, dentists don't go to the same institution that medical students go to. So, or podiatry, the doctors don't know anything about feet, and they don't know anything about the oral cavity because we have dental school, we have medical school or podiatry school. So they don't teach that in medical school. They spend, I think someone told me that they spend not 3 credit hours, but 3 hours total in the medical curriculum. And most 4-year medical schools, only 3 hours start to finish is spent teaching about sleep. But yet we spend 33% of our lives, or we should, sleeping every night. I mean, every human being should be able to sleep 7 to 8 hours without waking up, period. I mean, how many people can say that they do that? And why are you waking up? What's causing that? But because of the fact that I went to the University of Tennessee College of Dentistry, and the medical school was in the same general area, but it was across the campus, and we didn't go there, even though we had the same physiology teacher teaching both groups. As far as us interacting with one another, and because of the way we do insurance in the Western world, in the United States,
Right. Unfortunately.
I can tell Dr. Yolie, you have sleep apnea, but I really can't diagnose you because I'm not allowed to by law. I
Right.
have to have a medical doctor, complete the diagnosis.
Yeah.
But then that doctor makes a device for the patient or prescribes a CPAP machine, and then the patient can't tolerate that, and then the doctor can't make an oral appliance. So that's why we're talking today, because we have to
Right.
put this out there and explain that, I can send a patient and get a CPAP machine because I have a medical colleague that I can send, they can have a Zoom with him this week, and he can help them get a CPAP machine. If
Mhm.
they're like, look, I can't afford it. I need to make sure my medical insurance covers it. All right, super. You go through this path over here. If you can't tolerate it, then
Mhm.
let us know and we can write you a letter. Your
Mhm.
insurance, and most people don't know this either, but your medical insurance will provide for an oral appliance to be made by a dentist
Right.
if you attempt to wear the CPAP machine and you cannot tolerate it for any reason or you're not improving.
Right. Well, my brother, he is a retired veteran and then he has sleep apnea. He feels like he's going to get choked with that sleep apnea machine. So he refuses to use it. He's one of my motivations. I went to Vivos in Denver because I'm like, he's going to die.
Yeah,
And then, because he's not getting enough oxygenation or sleep, then he's suffering from anxiety. It's all like a domino effect, and he
100%.
refuses. So we got somebody, a provider in Orlando that's going to take care of him. And, hopefully, that's going to work out. But at least we're seeing a little bit of light at the end of the tunnel. There is solutions. I'm so happy that you're doing this. God bless you. And
Thank
just
you.
make sure that you put at the end, how can people find you and the phone number where they can reach you or the website. Thank you
Sure.
for doing what you're doing. God bless you and thank you for being part of our podcast.
Oh, well, God bless you, Dr. Yolie, and thank you for having me on.
Yes. God bless you. Have a good day.
Okay, bye
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 bye.
now.